75 years ago, the first external pacemaker was offered to a patient who was going to die. It was connected through, obviously, a thoracotomy, and they were connected to a box. This is a box. It developed and run by a gentleman and a company called Zoll. But 6 years later, they managed to do the first implantable pacemaker model. VOO means that it doesn't listen to the heart, it just paces. The first patient, the battery lasted 7 hours. But the cardiologist knew they needed another battery, so they kept changing the battery. And that particular patient lived for a subsequent 30 years, eventually, as pacemaker technology improved. In the 60s, demand pacemakers were introduced, transvenous leads. The standard of pacing nowadays, conventionally, is to go through the upper veins, the subclavian axillary veins, and find your way into the atrium and across the right ventricle through the venous system. And in order to improve longevity, they had lithium batteries, which made a huge difference. And now pacemakers can last up to 8 or 10 years. Initially, they couldn't listen to the atrium so that they could synchronize the atrium and the ventricle. But eventually, in the 70s and early 90s, they started synchronizing the atrium and the ventricle. And by the late 1990s, the emergence of cardiac resynchronization therapy to treat heart failure emerged. So this is our patient, a patient that came to see us, but initially went to India. Some people get this idea that if you have a condition, you should go to India. 75 years old man, complete heart block. Ejection fraction was 40%, and they put a single chamber pacemaker in him because that's what he thought he could afford, and that's what the recommendation was. 2 months after insertion, the patient had severe neck pulsations. Who has any idea what's going on here? By a show of hands. The patient has near syncope and dizziness, and I've shown you his neck. That is his jugular venous pulsation. He also had symptoms of heart failure. That neck demonstrates Canon A waves. Put your hand up if you're a physician, consultant physician, so I don't ask you this question. Okay, Dr. Njenga, what are the causes of Canon A waves? 3 causes. So a Canon A wave happens when the atria contract against the closed tricuspid valve. Tricuspid stenosis wouldn't cause it, but it's a good guess. You need to have atrioventricular dissociation. In other words, the atria is contracting, but the ventricle is closed. The 3 causes of atrioventricular dissociation are complete heart block, ventricular tachycardia, because the atria and the ventricle are doing their own thing, and a patient with a single chamber pacemaker who has a functioning atrium. So what should we do next for this particular patient? Well, they did an echocardiogram, and they demonstrated that in addition to having AV desynchrony, his ejection fraction has dropped to 30%. So what next? Well, of course, Dr. Swale would tell us that the first thing to do in the patient whose ejection fraction has dropped, and this isn't really moving, is to initiate the 4 pillars of heart failure. I'd like to spend a few seconds just reminding ourselves of those 4 pillars. The ARNI, sacubitril valsartan, and it's got 3 optimization strategies. You start on 50 BD, increase to 100 BD, and go to 200 BD. A beta blocker, which is optimized in 4 stages. Spironolactone or eplerenone, which is optimized in 2 stages. And the SGLT2 inhibitors, which are a single dose, start at the beginning and they're already fully optimized. So the patient received this. But it doesn't address the underlying problem. The underlying problem with this patient, the ejection fraction dropped from 40 to 30, and the reason why it dropped is because they had a double hit. The atria and the ventricles were not speaking to each other, and now the patient had a right ventricular pacemaker, and that right ventricular pacemaker created a conduction disruption because it wasn't going through the standard efficient system. What that translates into is a double hit, both atrioventricular and ventricular-ventricular desynchrony.